This presentation for Gonstead technique will be based on the thoracic spine. As you are familiar, the thoracic curve is made up similarly as the lumbar and the cervical curve. It's a combination of the vertebral body shape and the discs. The bodies are larger at the posterior, a little bit narrower at the anterior. This helps create the curve for the thoracic spine. When making adjustments to the thoracic spine, in particular the mid-thoracic spine, between T4 and T8, we have imbricated spinous processes. They're very long, so we need to alter our segmental contact point. Also, we limit our I to S in these adjustments. The spinous contact for the simple listing must be properly made. We do not make it at the tip of the spinous process or the posterior inferior medial or posterior inferior lateral aspect of the spinous process, because if we do that, there's a vertebrae that sits underneath that spinous process, and if we push directly through that contact point you see with the blue arrow, we'll be directing that force through the segment below. If we move up the contact point, segmental contact point, up higher onto the spinous process so we can get closer to the vertebral body, this will help us direct the force for the correction through the vertebral body. And that is the proper place to make the correction for the mid-thoracic spine. When making our contacts for a rotary listing in the thoracic spine from the TP, we have to remember that all the lateral to medial that we need in this segment is to push and direct our line of correction through the vertebral body. Often in clinic, I'll see students push lateral to medial as their primary line of correction, but the primary line of correction is always P to A and I to S, and the lateral to medial is very limited, only enough to drive that segment through the vertebral body, as indicated by the orange arrow here. The orange dotted line is straight P to A from the spinous process through the vertebral body, and the orange solid arrow indicates the lateral to medial component of the adjustment, along with the P to A and I to S. What we have here is a table indicating ranges of motion in degrees for different regions of the thoracic spine and in different planes of motion. You can see that in the flexion extension, it's very limited in the upper part of the thoracic spine as compared to the lower part of the thoracic spine. You need to keep this in mind when you're doing your motion palpation, that some motions are much easier to feel in different areas of the thoracic spine. Lateral flexion seems to be pretty close from top to bottom as compared to rotation, which differs greatly from the upper part to the lower part of the thoracic spine. The upper part of the thoracic spine behaves more like the cervical region, where it has much more rotational component. And the lower part of the thoracic spine behaves more like the lumbar vertebrae and has very limited range of motion as the facet angles change as we get closer to the lumbar spine in that transitional area. You need to keep this in mind when you're doing your MOPAL on your patient, because different regions will have different motions, different ranges of motion in different regions. Keep this in mind when doing your MOPAL on your patient. The next table here is just a brief table for the lumbar spine, kind of reflecting the continuation of the trends of the thoracic spine, in that flexion extension increases as we keep going down through the lumbar spine, and rotation also does increase as we go through the lumbar spine. The most amount of rotation in the lumbar spine is at L5. The thoracic spine, because of the kyphosis, often has a different presentation to the subluxations. Oftentimes, or occasionally, the thoracic spine, particularly the mid-thoracic spine, T4 through T8, because it's at the middle of the kyphosis, these vertebrae, when they subluxate, can subluxate posteriorly and slightly superior, meaning that they have an open wedge at the posterior aspect of the disc, and that's why we limit our I to S when doing these adjustments. We still have to facilitate the facet angle, so it's still P to A and I to S, but remember, we're going to have to drive that vertebrae straight down, not keep lifting it up from I to S to drive it more I to S. We need to limit that I to S just enough for the facets and then drive through the disc plane line because of possibly that superior aspect of that presentation. Here's an X-ray representation of the posterior superior subluxation. You can see that the vertebrae in the picture has a slightly larger disc at the posterior aspect, and you can see the front of that disc space being narrower, and you can see the reactive sclerosis at the level where the arrows are, also the levels above and below the arrows. You can see the reactive sclerosis in the anterior parts of those vertebral bodies. That's because the load and weight and stress on those discs is being shifted to the anterior part of the discs, and those vertebral bodies and end plates are responding with the sclerosis. So this is an example of a posterior superior presentation for subluxation. This is taking the same X-ray and showing you where we would contact this vertebrae to make the correction at the vertebrae, which is highlighted in blue here, outlined in blue. You can see here clearly on this one that if we pushed P to A on the posterior inferior aspect of that blue spinous process, we would be generating the force and directing it through the segment below the actual segment we'd like to adjust. Therefore, we move that segmental contact point up as high as we can on that spinous without touching the one above, which would be the red one, so we can drive P to A and I to S through the vertebral body directly without influencing the segment below or above. This is a case we had in the clinic about 10 years ago. It's a picture of a patient that has a thoracic spondylolisthesis as well as that posterior, well, really it's not posterior, it's a spondylo, so it's going anterior, but it has an open wedge of the posterior aspect. Difficult to see on this image, so we'll go to our next image, where you can see where the green arrow at the top is showing the vertebrae that has the anterior migration of the vertebrae. It's actually T4, showing it has gone forward at least like a grade 1 spondylo presentation for that thoracic vertebrae. And you can also see below it where the other arrows are indicating where they have narrow discs at the anterior, open at the posterior, so posterior superior misalignments. But at that T4 where that upper larger green arrow is, it demonstrates the anterior slippage of T4. Very odd presentation. When we saw this, it's one of the few we have seen, but it was definitely the largest one I've seen in the thoracic spine. We had a couple doctors look at this, and that was what was the area of the patient's complaint, was the upper back. And when we did adjust this patient, it was not adjusting T4. We actually had to adjust the segment below like we learned for our lumbar spondylos. So we had to adjust T5, P to A, I to S, and then following the disc plane line here, which is now S to I, following the direction of the large green arrow at the top. Okay, this slide asks the question, how many articulations does a thoracic vertebrae have? 4 to 6, 6 to 8, 8 to 10, or 10 to 12? I ask this question because I want us to understand how complex sometimes a thoracic adjustment can be. This image here is showing the complexity of the ligament structure of the costovertebral and the intervertebral ligament connections. There is a massive amount of structural support at these levels. So when adjusting the thoracic spine, I believe it's one of the more complex areas to adjust. Most people think it's a very easy area to adjust because it's easy sometimes to, when you're learning how to adjust, to get the audible here. But I think it's actually sometimes the most complex to get the proper and correct adjustment made, because there are so many articulations for each thoracic vertebrae that one impulse sometimes does not make the full correction. And you need to learn how to identify exactly where that fixation is as you're making your correction. This slide here gives us a graphic view of the articulations of a thoracic vertebrae. Upper and lower, we have our intervertebral discs. We have our upper and lower facets, which make 4 articulations. We have our costotransverse, which is another 2 articulations, and our costovertebral, which can be either 2 or 4 articulations. If you look at the bottom graphic here, you see the red circle, which shows that a rib is coming in and it kind of bridges the disc space, and it has a facet on both the inferior and the superior aspect of that rib on those different vertebral bodies. So oftentimes a single rib can contact two vertebral bodies, again making the thoracic spine a very complex place to adjust. Not just our normal facets and discs to be concerned with, but our costovertebral, costotransverse, and makes it very intricate. In Gonstead, if you analyze your segment, you establish your listing, and you make your initial correction. Let's say the initial correction was a PLS correction. Spinous contact, you push P to A, I to S, left to right on the patient with a nice thrust. You get an audible, but you go back and you do your post motion palpation, and you notice that the vertebrae is not moving as well as you would like it to after the adjustment. But you need to determine in which plane it's not moving. Is it the flexion extension? Is it lateral flexion? Or is it rotation? Because there may be another component of that with a fixation in this massive complex of ligaments and bones coming together that still needs to be corrected. So we may need to correct the P to A component because that's not moving but rotation is. Or we have the P to A component, flexion extension component has corrected, but the rotational component has not. So we have to go in there and really dig in deep to our MoPal to determine which component of that subluxation or that fixation has not been corrected. And it is okay to go back in and give a second adjustment to that vertebrae to correct the component that you did not correct with your first impulse. But you have to do your impulse, you have to do a post check with your motion palpation, and you have to determine whether it's fully restored motion or partially restored motion. And if it's not fully restored, you can go back in, delivering a second impulse to that vertebrae to try to make that full correction. It happens a decent amount in chiropractic, but you wouldn't know unless you actually did a full-on post-evaluation of your patient. We're going to move on to the topic of scoliosis. Can you list the causes of scoliosis? You may think that's a simple list, but things that can create curvatures of the spine or adaptations of the spine are numerous. We have two major categories for classifying our scoliosis. One is structural scoliosis. If you look at this list here, it gets pretty complex looking at all the different ways that a structural scoliosis can be developed in a patient. The one that we're most familiar with and the one that is the most popular or most common is our idiopathic, generating from infants, juvenile, or adolescence when you first see these coming in, primarily through adolescence. But it's idiopathic. It's built into the genetics, and you're going to see it happen, and it will happen no matter what we do for chiropractic. But our job in chiropractic, even with the idiopathic scoliosis, is to always make sure that spine is working at its best, keeping the nervous system free of interference. Because even if it's that idiopathic scoliosis, by keeping that spine adapting and adjusting well to the development of that scoliosis, we can give them a better chance of mitigating the severity of it at times, making sure the nervous system is clear, and even reducing the overall extensiveness of that scoliosis with early on care. The neuromuscular development of a scoliosis is not as common, but we have seen this in practice, or I have seen this in practice. The upper motor neuron lesion. We had a patient who had an automobile accident, and he had an upper motor neuron lesion. It was a brain injury, and his scoliosis developed with his spasticity well after the accident. We do not know why it was a delayed onset to this neuromuscular motor neuron lesion, but initially after the accident, the patient did not present like this. He presented into his full upper motor neuron lesion with his spastic presentation, almost like a patient with cerebral palsy, very spastic, but it developed over 4 months post-injury. And my guess is that he was subluxated in the upper cervical spine, possibly occiput, atlas, and that it was never corrected. So immediately after the injury, he recovered from the actual initial head injury, but pressure was not taken off the nervous system, especially at the level of the brainstem. He progressively developed the classic signs of upper motor neuron lesion. We did take care of this patient for quite a long time in the clinic. He was wheelchair bound. He had a bit of a scoliosis, not as dramatic as another patient we had with cerebral palsy, but we were able to deliver care to him. It was primarily in the cervical spine. It did relax him a little bit. We didn't see any really life-changing changes with him, but we did see some relaxation of the spasticity in the days following an adjustment, and that was really good because he had extreme spasticity in both of his hands, but in particular his right hand, where he would his hand would go into spasm and go into a massive grip. It would go into contraction of the hand, and that limited his ability to use his hand because it was always in a contracted state. And after the adjustments, it would relax a little bit. And we really worked hard on this, but it was a really tough go for us. Moving on to cerebral palsy. We have had a patient who had cerebral palsy. She developed, again, cerebral palsy late in life, and I cannot remember what initiated the onset of her cerebral palsy. But she also went into a great amount of spasm, unilateral spasm, so she developed a huge curvature of her spine, actually. And we did take care of her. It was progressive. It was a very unusual form of cerebral palsy. And unfortunately, she was actually in her 20s when she developed the condition. She was a school teacher and had to stop teaching and then was bound to a wheelchair. And we would pick her up out of the wheelchair and put her on the table and adjust her. We actually did x-ray her, and I have those x-rays. See if I could dig those up for you guys later. But you will see some of these. Not as common as our idiopathic scoliosis, but you will see some of these other folks who present to your office because of neuromuscular issues. Okay. Going down the list here, we have myopathic, we have congenital, which can kind of go up towards our idiopathic, but it could be from more of a structural cause to the scoliosis with failure of segmentation, hemivertebrae, unilateral sacral inferiority, where sacrum, which is a very malformed segment oftentimes. We see a lot of congenital anomalies at sacrum. We have neurofibromatosis, mesenchymal disorders, Marfan's, and I have had one Marfan's patient. They did not present with scoliosis, but they did have a dissecting descending aorta. That was not, I'll tell you that story a little bit later in the quarter when we talk about indications or contraindications for adjusting. Rheumatoid, I haven't really seen rheumatoid create a scoliosis. Trauma, of course, if you have a fracture, could obviously affect the structure and then create adaptation to that. Extraspinal contractures, this can go up into our neuromuscular stuff because those are extraspinal, or some of those are spinal and extraspinal, but there are few conditions that can help lead to that. Infection of the bone. Well, if there's infection, typically will cause, often can cause a compression fracture because of the pathological fracture of the vertebrae, creating an adaptation, which could be create a scoliosis. Metabolic disorders. These are typically diseases that cause bone softening, and adaptations can occur based on the type of stress put on the spine. And tumors, again, the tumor itself can actually be a space-occupying type tumor, and the body adapts itself away from the tumor to make room for it until it becomes a point where you have to address it directly, or it can get into the vertebral body, again cause a compression and develop a scoliosis from there. So there are many, many causes that can cause structural changes to the spine, and particularly can get as far as scoliosis. The functional scoliosis is something that we as chiropractors can definitely make a big difference with the patient as far as making a correction to it. The structural scoliosis is always one I want to work on this patient to try to limit the overall long-term effects of detrimental effects of abnormal curves, keeping the nervous system in its best operating position. With the functional scoliosis, there's always an opportunity for us to make a correction to the scoliosis if it's identified as a structural. We have postural scoliosis, hysterical scoliosis. The hysterical scoliosis typically occurs after a patient has had some sort of trauma, either physical or emotional trauma, and they get into a state where they will adapt a positioning that may create the scoliosis. I've only seen this once in practice. Nerve root irritation, herniations and tumors, if those things can be eliminated, they can definitely take the adaptive curves away. And segmental and postural positioning dyskinesis, well, this is all related to our subluxation. We have a segment that's not in the proper position, can cause adaptations, especially if it occurs in the lower lumbar spine or pelvis, where the body's now adapting and creating a curve, and we can make those corrections and eliminate that scoliosis. It could also happen with a subluxation of atlas, causing maladaptation below that. So it can happen either way. It says related to leg length inequality, not necessarily a short leg, but if you have a chronic pelvis subluxation causing lowering of a leg, or you have a chronic spasticity of, say, the quadratus lumborum, causing the patient to be pulled to one side. The patient's body does not want to stand to one side leaning over it. It's going to want to adapt. So it'll curve itself back to level itself with the horizon and get that weight bearing back over the pelvis where it wants it to be. So if we can correct the leg length unleveling or inequality, we can then correct the scoliosis. And related to contracture around the hip. Anytime we have a contracture where it alters our posture, our body wants to adapt, but when it does that, if it pulls our spine off to the side, the spine wants to pull itself back to right itself in the horizon and will create a curvature in the meantime. I have had a patient with a structural idiopathic scoliosis who I started seeing approximately in her early 30s, and I have x-rays of her over a 10-year span, and with chiropractic care along with her exercising, beginning an exercise program, she was a couch potato prior to this, her curves reduced like 4 degrees on one curve and 2 degrees on another. And it doesn't seem like a lot, but the good thing is the curves weren't progressive. Even though she was aging, and typically after 30 you start the degenerative process in the spine, her spine was better supported with her exercise and chiropractic, and actually the curves reduced a little bit. So she was in much better shape over the 10 years of care and her beginning and initiating an exercise program, which served us very well. What's important to remember is the coupled motion of the spine, both the thoracic and lumbar spine. It differs depending on what type of posture your patient's presenting with. If your patient is seated and relaxed, the way we want our patient when we're doing our mopal, we want them to completely relax. Let those tonal muscles, our postural muscles relax, and just kind of hang back there on the ligaments, just being so we can do our passive range of motion. When we do that, when we motion or laterally flex the patient to the left, those spinous should deviate to the opposite direction to the right, as indicated in the top part of the diagram with the orange arrows. If the patient is standing or sitting up straight where they're not relaxed, when we go to mopal the patient and I laterally flex this patient to the left, that coupled motion will now force those spinuses to come towards the side of lateral flexion, which is not our typical expected motion. And this can happen if the patient's sitting up too straight trying to help you. Most patients, when they come into the chiropractor's office and you sit them down for mopal, they want to demonstrate they have really good posture in front of the chiropractor because they're there for their back, so they want to show off. But then I tell them, I said, hey, I know you're in the chiropractor's office, but I need bad posture from you. And you have to make sure that they get very, very relaxed in the proper position so you can get the actual motion that you're intending to get from mopal. So if our patient has some pelvic unleveling, whether it's from a subluxation, malformation of a pelvis, the sacrum, or an anatomical short leg, this tends to produce a scoliosis that deviates to the side of the lower leg. It typically has a lumbar spine with body rotation to that side, creating a rotatory scoliosis, as we'll see here. Okay, that's the typical presentation if somebody has a deficiency or a lower pelvis on one side. For whatever reason, it creates typically a rotatory scoliosis. Here's an example of a rotatory scoliosis with a patient that has a humongous leg length deficiency. You said, oh my goodness, that's a lot. How could that happen? I have seen this on a patient that had 1.5 inches shorter leg, congenital, with no apparent pathologies, fractures, or malformations or disease processes. And the way she made up for this when she would walk is she would walk on her toes. She wore high heels all the time. That's the way she can compensate and get enough movement in her pelvis to compensate for that leg length deficiency. And when she walked with heels on, it looked nearly natural. I mean, it looked like she didn't appear to have any leg length deficiency. But if you took the heels off her and asked her to walk, you could definitely see the difference, because she had to walk flat-footed on one side and on the toe on the short leg side. And when I asked her to stand for the x-ray, she had to stand flat-footed. So she would drop one foot and then she'd have to bend the other leg just to get her feet flat on the floor, which then allowed me to see the pelvis deficiency. But we had to work it so we can get the proper x-ray, and the proper x-ray was for her to be flat-footed as possible, but it was really hard for her to stand completely flat-footed without bending a knee, because there's such a huge difference in her leg length. I have seen this in a couple other patients. I've had 2 patients who have had a leg length deficiency similar to this one, over 1 inch, but both of them had femur fractures as infants. Not infants, I'm sorry, as small children. One, I believe, was at 5 years old, and I think the other one was at 6 or 7 years old. One was hit by a car on his bicycle, and the femur repaired, but it didn't repair like they would repair it today. The actual femur bones or femur fragments overlapped each other, so it actually created a shorter leg. Had a big callus down there in the femur, but it grew, was nice and strong, had a very productive life, but just had a very, very short anatomical leg. And he presented this way as well. And in this x-ray here, this is the simple scoliosis, as we call it. It's not the typical way we see this. This person has a little bit shorter leg on the right. We laterally flex them to the right, and the spinuses are going left for the scoliosis. That's not the typical presentation of a scoliosis. This would be a typical presentation of you doing Mopel on your patient, but not a typical scoliosis. Typically, the lumbar bodies rotate to the side of the short leg. Okay. Subluxation and leg length, you guys have had this in other classes, but what it shows here is when we have a PI ilium with the orange arrow indicating the PSIS. As the PSIS goes posterior and inferior, because of where the axis is in the SI joint, it causes the femur head to raise up, as indicated with the red arrow here. So it's kind of like a teeter-totter. As one end goes down, the other one goes up. Okay. Conversely, for AS, the orange arrow is indicating the PSIS is going up, and again, the teeter-totter is going to push the femur head down on the other side of that joint. So the SI joint acts as a pivot point. So as we have the PSIS going in one direction, the femur head goes in the opposite direction. This is important in our Gonstead system because it helps us determine whether we're going to use helps us determine our pelvis listings, our measured deficiency as compared to our actual leg length deficiency, and gives us an indication of whether we may want to incorporate a heel lift in with the patient's care. Heel lift rules. In Gonstead, we occasionally will use a heel lift to help a patient who is not holding their subluxation. They're not making the progress with the care that we hope. As you see here, the #1 rule is the subluxation is unstable, meaning that we're adjusting the patient, we're getting good movement, but we're not getting that correction to be long-lasting. The results are just not staying. The second criteria is that the AD is more than 6 millimeters, the lumbar convexity is to the short side, and the lumbar body rotation is also to the short leg side, or short or deficiency, leg length deficiency on that side, or pelvic unleveling, however you want to word it. And the patient must have a fully developed pelvis, as well as under the age of 45. Early on in practice, I did experiment with heel lifts with my patients, and I had very little to no results with heel lifts. The one positive result I did have with heel lifts in my patients who had the criteria was when I put the heel lift in, their #1 benefit for that was their feet. Oftentimes, these people who have a short leg or a pelvis unleveling, their feet start to adapt to this short leg, where one foot will want to make itself a little higher, one will make the arch will drop on one foot, the arch will raise on another, and I think it's the body trying to accommodate the distance. So on the long leg side, the foot tends to go flatter. It's trying to shorten that leg, kind of doing the inversion. And with pronation of the foot, it causes an increase in valgus angle, and that makes the leg essentially a little bit shorter. And on the other side, I see the arch raise up, and it tries to hold that foot from going into pronation, essentially trying to make the leg longer. Does it make an overall difference? Maybe a millimeter or two, if that much. But on the foot that gets forced into the arch, I also see a hammer toes have formed on those patients. And in both my patients who I gave heel lifts with, who actually had leg length deficiencies, anatomical leg length deficiencies, mentioned that their feet were the #1 thing that felt better with the heel lifts, so they continued to wear them. One of my patients said, hey, I want all the heel lifts you got. I'm going to put them in all my shoes so I don't have to worry about trying to get this heel lift in and out of my shoes. And to this day, I just kind of gave him the place to go order them himself because he knows what he needs. And to this day, and he still wears them. And that's probably 20 years of wearing a heel lift. And like I said, the #1 benefit he saw with that was his feet. The other patient, he really didn't see it much because he was a plumber. He didn't notice the difference until he retired from full-time plumbing, where he was moving around all day in different positions, you can imagine, as a plumber, and we went to work at Home Depot. He went from very physical all day to standing or walking all day, so standing on his feet, and that's when he noticed his feet were bothering him the most. When his heel lift wore out, he realized that the foot started hurting again. He goes, hey, I need more heel lift. So we gave him a heel lift, he put it in the shoe, and his feet did much better with it. So not a whole lot of benefit with the spine with my experience, but I've seen people really benefit with their feet. So remember that at Life University, you have the benefit of foot levelers. Foot levelers are also called pelvic stabilizers. And if you can get your free pair from Life, you should go get them. They'll greatly benefit your foot support and pelvic leveling. Here's a series of pictures of a young lady who has a pretty severe, pretty advanced scoliosis. I have patients with this or even more advanced than this who did not have a scoliosis correction. The correction depends on the severity of the curve, if it compromises the heart or ribs or the lung field, if they are able to keep their torso, their posture over their pelvis. This young lady, even though she has a pretty sharp scoliosis, her rib cage is slightly compromised, but her lung and heart space are still very open. Okay, the picture on the left is a picture of my patient. She was an older lady, probably in her 60s, I would guess, at the time of this picture. And when she walked into the clinic, if you had a trained eye, you'd notice that her torso looked shorter than typical in proportion. That's because of the severity of her scoliosis in the thoracic spine actually made her a little bit shorter than she normally would have been, obviously, if she had a straighter spine. She was very functional. She did not have any problems with heart or lung field, although you see the left side there is looks like it's compromised. But remember, if you take the entire lung field and thoracic cavity into consideration, her lung field and thoracic cavity are still very open and very functional. And she had a daughter. Unfortunately, this is not the daughter's picture on the right-hand side, but her daughter had almost the same scoliosis as the mom, but it was more of a lumbar scoliosis. Mom had hers almost all in thoracic. The daughter had a thoracic and lumbar, and the daughter chose to have a surgical correction to her scoliosis. And after the surgery, she was more miserable than she thought she was going to be, and wished she hadn't had the surgery done. The mom was a little older and decided not to ever have surgery. She was a nurse, spent an entire career as a nurse, and did just fine. So there's a lot of factors that go into whether surgery is needed, required, or necessary. So one chose yes and one chose no, and the one who chose no looked this is her picture on the left here. Oftentimes with scoliosis, people ask me, can I correct it? Especially if it's an adolescent or pre-adolescent where you're starting to see the formation of the curve. They ask, can you correct it? Sometimes the answer is yes, especially if it's a functional scoliosis. Even if it's a structural or idiopathic scoliosis that's developing because you may have some history that the mom has one, and you could work on limiting the overall extent of that curvature. It's important to keep motion in the spine and pressure off the nervous system. When patients have scoliosis, they can be very functional, but it does compromise the biomechanical integrity of the spine over time because the spine is now bearing weight in areas that it normally wouldn't. The discs aren't absorbing all the shock in the spine. The facets are being loaded unevenly. The vertebral bodies are experiencing uneven weight distribution. So over time, these spines tend to progress with degeneration. Matter of fact, I had an aunt who had a very severe scoliosis, and by the time she passed away at about 98 years old, she was very bent over and had to walk with a cane, not so much because she was in pain, because her scoliosis advanced to the point where she couldn't stand up anymore, physically couldn't stand up. Okay. So obviously there's a lot of rib humping and malformation accompanying a scoliosis of this manner with as much rotation as we get to the vertebrae. This is what makes this candidate not a good candidate for the knee chest table, especially when we have a lot of curvature and a lot of adaptation of the rib cage. The patient will not be very stable on the table, and our lines of correction to correct the subluxations are not always in the normal lines of correction because we have to adapt for the rotation of the spine along with the curvature. So this type of patient typically is not very stable in the knee chest. That's why we adjust them on the high-low. And because of some of these structural asymmetries, making corrections to these scoliosis is impossible. Okay, there are some treatments for scoliosis if it's caught early in the adolescent or prepubescent, that if they detect a scoliosis beginning, they can use some external bracing to try to guide that spine through to grow straighter. You know, Wolff's Law, the spine will respond, or the bones will respond to the pressure that's put on them. So this is one method which they are bracing this young lady, trying to give the body the opposite input from what the scoliosis is developing into. And I believe that this is a viable and practical change to try to guide that spine into maybe progressing a little less than it might by forcing it straighter, but from an external means. The surgical means they use, where they use large rods and pedicle screws, are very permanent and very, I wouldn't say debilitating, but definitely alters life and motion after that. But that's a personal decision on how aggressive the scoliosis is. We'll talk about that in a minute though. But I like this approach. It gave the young lady who is very active a chance to stay active and still try to mitigate some of the progression of her scoliosis. And then the next slide, we'll see she was a young cheerleader and was still very active and could do most of her activities even with her bracing on. Okay, medical treatment of scoliosis. This is where your patients will ask you, what can you do for my young daughter, typically, more than so a young man. There are a lot of factors that help you guide the patient through care of the scoliosis and when you need to have another medical professional on board co-managing the case with you. Okay, the choice to choose what type of correction they may want comes down to many factors. Like I say here, it includes a psychological factor. What's the maturity of the patient? What's the magnitude of the curve? What's the potential or the actual progression of that curve? How aggressively is it moving forward? Some of the curvatures, the thoracic curves, are at higher risk for progression than thoracolumbar curves or lumbar curves. Okay. General guidelines include getting a reevaluation every 4 to 6 months. Thankfully, in Gonstead, our X-ray is the perfect X-ray for monitoring scoliosis. It's very similar to the scoliosis screening view, which is taken from the top of the thoracic spine through the lumbar spine. And in the Gonstead picture, our picture is actually larger than that because we go from the occiput through the ischial tubes, so we can see the entire spine plus any other contributing factors which may involve pelvic unleveling. Okay. To determine whether the patient needs medical intervention, I will, if I see the scoliosis progressing and if the patient's posture is being affected, or we believe that aesthetically the patient, not just aesthetically, but biomechanically, the patient is being compromised. What I like to do when I have the patient in the office and I take the x-ray, what I do is to see how well they're adapted to their curve. I actually drop a plumb line because I have plain film in the office. I actually take a plumb line and I hold it over the odontoid on the x-ray and see if that plumb line falls into the center of sacrum. If that does, that means that patient is very well adapted to their scoliosis, meaning that their head and their pelvis are staying right over each other for weight bearing. I can take my postural measurements, seeing if there's any shoulder unleveling, hip unleveling, and I can monitor the ribs, and I could also monitor progression. I've had a couple patients with pretty extensive scoliosis, but were perfectly adapted, meaning that their head was located directly over the pelvis for weight bearing, and their shoulders just had a minor unleveling in the shoulders, and they were doing very well under chiropractic care, and their bodies were adapting very well. Once it reaches a certain point or a certain rate of progression, you must refer them to the orthopedist. You need to have someone on board with the case so the patient knows all of their options, and it's always a personal decision from the patient or their parent and the patient on whether they want to go ahead and have any corrective surgery to do this. Once they do the surgery, it's irreversible. But I have had patients who've had pretty extensive scoliosis. I had a really nice case meaning a nice case to learn from, not a nice case for the patient per se. But the patient had a 45-degree scoliosis in the thoracic spine. Her rib cage was overlapping her pelvis. And when she was 15 or 16 years old, she chose to have a corrective surgery. And I actually have her case here that we're going to take a look at in a minute. They did straighten up her spine very well. I have seen the corrective pictures. I actually have seen an in vitro picture when they took it during the surgery on the table to see how much of the correction they actually made. And of course, I have a series of films of her while I was caring for this patient. But her correction was very, very good, and I'll show you why I liked it more than I liked some of the others. Okay. Here is a picture of a scoliosis patient. As you can see, not only is there a large scoliosis here, but you can see a huge wedging at the L4 vertebrae. When I see this in a patient, I really try to work on that area when I find subluxations there, because I believe that there is room for improvement there. This is a fairly young patient because you can still see riser sign on them. So I'd like to get a hold of these patients as soon as I can to work on correcting subluxations to see if we could limit the total overall progression of the scoliosis. I want to do the best I can to keep this scoliosis under control. This is a picture of a patient who has a spastic scoliosis from cerebral palsy. You could see the extreme curve in the lumbar spine, and the thoracic spine here is the only reason it is curved is to adapt to the lumbar spine. And you can see that the plumb line is kind of the plumb line is put on this x-ray here. You can see that the top of the cervical spine is nowhere even close to being over sacrum. This is a very ill-adapted scoliosis, and this is the one from the neuromuscular skeletal cause of a scoliosis. This slide is just a brief explanation that there's no scientific documentation for the role of exercise manipulation or electrical stim for the management of scoliosis. Obviously, the picture here you see is very severe. Be difficult to manage that case in a variety of ways, but even though there's no documentation that manipulation or spinal adjustments can fix or manage a scoliosis, we know by keeping that spine functioning as best as it can and keeping that nervous system free of interference that the body will have the best chance it can about adapting to the scoliosis. Okay, this is my patient who had that scoliosis at about 15, 16 years old. Like I said, it's about a 45-degree curvature to the left of that thoracolumbar curve there, and her left side of her rib cage was actually overlapping her pelvis. So what they did is they decided to put a single rod in here, and this rod is not screwed into the spine. As you'll see, it's just leveraged into the spine with some hooks. Have a close-up in a minute. But the reason I really like this case is, one, I like the way they corrected the scoliosis. They left a lot of room for this spine to have its own movement without locking it in. With a typical double Harrington rod presentation, this is a single Harrington rod. And normally you'd think, well, wow, how could I adjust this patient in the mid-thoracic spine if she had a subluxation? But I was able to adjust this patient there. For the first few months I took care of her. Her primary complaint was upper thoracic and cervical because of the rod being connected in the upper thoracic spine and locking it in. The upper thoracic spine and cervical spine were the areas that were really adapting and struggling and stressed because of the rod. So I took care of her there quite a bit, mostly lower cervical, upper thoracic. But as I would run the scope down through her, I kept noticing I get a subluxation in the mid-thoracic area. And I asked her if it would be possible if she would let me try to adjust her in this area. And she says, well, no, I'm not really comfortable with that. So kept working with her, kept getting a subluxation there, and would ask her, can I adjust here? One day she said, yeah, we can try. So I had her prone on the high-low. She is not a candidate for the knee chest because of the rod. So I put her on the high-low, and I'm just easing into the area. It's approximately T6 or T7, and I was contacting the right TP. So I wasn't on the rod, I wasn't contacting the rod, and the rod was not connected to the segment I was going to attempt to adjust. So pretty safe. But I just had to be careful on how much I was going to push P to A because she has the rod connecting in there, although the center of the thoracic spine is free moving for the most part. So the first time I was in there, eased down onto it, she started to feel pressure build up. She said, no, I'm not comfortable with that, so I had to back off. Next time she came in, I tried again. She says, I know I'm not really comfortable with that. And finally, I think it was the third or fourth time, she felt comfortable enough. So I was able to ease down into that and gave a very light impulse on the TP with the TP contact and got a little audible. And it released the fixation a little bit and got a little bit of movement in there. And then about every third or fourth adjustment, I would adjust in that area of the thoracic spine. And she did pretty well. The other area, which she had a concern on here, and it didn't bother her every visit, was her spondylo. She has a grade 2 spondylo at L5. And she stood up for work all day, worked in a factory, so she was very productive. And when that spondylo was symptomatic, we would adjust it. And it was a sacral adjustment on the high-low, and she did very well. She was a very good patient, responded really well to care. But this is a patient who I would tell that, yeah, are you a candidate for lifelong chiropractic care? As I think everybody is, but her especially is, because her spinal movement and stresses on her spine are really being predicted or dictated by this rod, so we had to work a lot around that rod. Now, would you accept this patient for chiropractic care? Kind of a moot point because I already told you what I did with this patient. But I wonder, what would you do if you had that patient come into your office for the first time? Okay. Here's a close-up of that rod. You can see at the T4, T3, T4 area, the rod has a hook, and it hooks right inside the lamina on the posterior aspect of that vertebral segment. So it just straightened her out. There's the little ratchets, or they're little connecting ratchets on the rod. So what they did is they connected her in, stretched out those hooks, ratcheted out until it locked in, till they got the posture they wanted, and then they cut the rod off to limit just the exposure of additional rod. And that's where she is. And it straightened her out pretty well and allows for as much motion as you can allow while correcting the scoliosis. I'm not sure why this isn't a more common use of intervention rather than the pedicle screws, but I really like this one, and I think it was a great case because she really did well with chiropractic care, and I like the surgical correction of this scoliosis. This is a review question for you. Which is the preferred table to adjust a T10 in a patient with a scoliosis? Pelvic bench, knee chest, high-low, or drop table? Well, the actual answer on this one is the high-low table, because I mentioned earlier, and you should remember from your knee chest class, your do's and don'ts for your indications and contraindications for the knee chest table are that we do not put the scoliosis patient on the knee chest table because they're not as stable as we'd like them to be, because of the lines of correction and just their ability to stay stable on the table. So this is definitely a high-low table adjustment. This is one of our patients with a scoliosis, and this is a patient who I believe has a very well adapted scoliosis, because when I draw my plumb lines down from the top of the spine through the pelvis, you can see her odontoid is directly located over the gravity line of the sacrum. Very little shoulder unleveling and very well aligned over the pelvis. Even when we look at her lateral posture, those weight-bearing lines look very, very good. So here's a patient with a biphasic scoliosis and extremely well adapted. This is the type of scoliosis we like to see in the office, because we have a really good chance of keeping them there and them to have very little to no progression. Although we probably will see some progression of these curves with age as the discs start to dehydrate. This is a picture of a lumbar fusion to stabilize what was called, quote, an unstable lumbar spine, which I really don't know what that meant when they told the patient this, but they did a fusion. What you see here are the pedicle screws with no rod, and what you see at the bottom are the screws going into the lumbar or L5 and sacrum with a rod. Now, doesn't mean they didn't complete the fusion. They did. They did what's called a bony and mechanical fusion. If you look on the X-ray on the right, if you look posterior to the vertebral bodies, you'll see a very opaque line running vertically through the screws. What they did is they do a laminectomy. They cut off the laminas and the spinuses. What they do is they mash those up. The surgical tech mashes them up right there in the surgical room. They roll them out into it's a paste. They create a paste with it. They roll it out to a long paste that's as long as and about as wide as your finger. What they do is they put that right in there next to those bony elements and screw right through this bony paste. What happens is that bony paste will then ossify and create the fusion. So this is a combination of a bony and a surgical fusion on the same patient. I've been in a surgery for I've been in a surgery for a lumbar fusion and decompression surgery. Very similar to this one, but they did the bony fusion with the bony mash that they made and stuck it right in there on the lamina area, but they did not put the screws in there. So they were just hoping that the bone mash that they put in there would then ossify and help limit the motion of those segments. I said, what happens if it doesn't take? And the surgeon says, well, the body just reabsorbs it and it goes away. Because there were two surgeons in on the surgery that I watched, and they were debating whether to put screws in or not. It was less invasive to put the screws in. They decided not to. They decided that the decompression was the major part of the surgery, which they were trying to relieve pressure on the spinal canal there. This was my patient. I knew that the surgery that they were doing was not going to fix the problem the patient had, but the patient begged for it, and the surgeon agreed to do it, and I knew it wasn't going to be a good result. And afterwards, the patient was no better. He actually had more lower back pain because of the surgery. He just felt uncomfortable, and he progressively got worse afterwards. But part of it, there was a psychosomatic component to that. Then I'll tell the story probably later in the quarter. Okay, this is a case of a very long-term patient of mine. I've been caring for her for 20 years. And it had been more than a few years since we had an X-ray, and she called me up and says, hey, I need to come in. I had a fall. I fell down the steps. She's very athletic, so she said as she was falling down the steps, she was able to get one hand on the grab on the railing. So as her body was going down the stairs, she kind of jerked herself with her arm on the right arm. And she said that she lost motor function of her right hand. I said, well, come on in right away. Let's see what we can do. So, of course, because of the trauma and the serious neurological component of this, I retook the X-ray. It's very difficult to see here, but she had a lot of rotation in the upper part of the thoracic spine. I did all the neuro, and Okay, this is a case that is a very interesting presentation. It is a construction worker who injured himself on, I believe it was July 3rd, a bunch of years ago. He was working in Jacksonville, Florida. He works for a construction company. He works for a company that put gas tanks underground for gas stations, the big storage tanks that we pump out of at the gas station. He was standing on the edge of a pit in the ground, a hole in the ground that they had dug, and he was standing on the edge of it, and the edge of the pit started to give way, so it started to fall. So as he started to fall, instead of just falling straight down, he kind of pushed himself out a little bit and made himself do a complete flip. So he went head over heels and landed back on his feet. He landed feet first, and of course, from falling from that far distance without really control fall, he then compressed down and kind of fell down onto like a ball and then fell to the ground. So he landed on his feet and then had a lot of compressive forces come down on him. So just by the nature of the injury, you can imagine some of the potential trauma to the spine. So he drove all the way from Jacksonville, Florida. His wife was also a patient. She says, "Hey, my husband's on the way. He needs to see you right away." She said he hurt himself and he's hurting really bad. He needs to come in. I said, "Well, send him right to the office. We'll get him in." So this one is a great case to go through all of your examination criteria. So he gave me a mechanism of injury. Very good description. We know it was a trauma. We have a suspicion of what we may be suspecting, things that might have occurred because of the nature of the injury. He was about 6'2", 6'3", about 240 pounds at the time, so a really big guy, pretty fit, but big person. So I do the examination and I'm looking at the spine, and you can see inflammation around the spine, especially lower thoracic, upper lumbar, and the lower lumbar area. We get a lot of edema, scope reading of both of those areas, very warm, and two telltale signs that you guys already know. Spondyloid L5. When sometimes you get the spondyle, you know that L5 spinous can migrate back towards you posteriorly. Well, he was demonstrating that. He had inflammation or edema all around that area, and you could also see the L5 spinous poking backwards. Go all the way up to, I think it was T12 or L1, I can't remember. We'll see on the next slide. Also the same presentation, that the I guess it was L1 or T12 spinous, as he was in a flexed position, you could see that that spinous was a little more prominent than the other ones. And when you went to go into extension, it would not go into extension at all. So I wrote on the examination, my examination paper, I wrote compression fracture L1, spondylo at L5. And I took the picture, and here's what we saw. Compression fracture at, I think it was T12 now I see because there's a rib on it. So T12. No, it's L1. No, it's L1. So the picture on the left, you can see that there's a slight concavity or convexity to the right with a decrease in the height of the vertebral body as we go from left to right. It's narrower on the left than it is on the right, so there's a lateral wedging here of the vertebrae. And on the right-hand side, you could see the massive compression fracture. The arrow's pointing to the actual fracture fragments that are overlapping each other on the anterior part of those vertebrae. So what happens here is when the lumbar, oftentimes in a compression, like forced flexion compression fracture of a vertebrae, it tends to elongate the vertebrae as it crushes down on itself. And if you look at the posterior aspect of T12, if you line it up with, if you line up the posterior aspect of L1 with L2, you'll notice that the L1 vertebrae sits a little bit posteriorly when you're looking at the posterior aspect of that vertebrae. I don't have a line on here, but you can see it. So that's what made that L1 vertebrae have a more prominent spinous. It would not want to go into extension as well. So same patient, same trauma, L1 compression fracture and L5 spondylo. I believe I have the spondylo picture. There it is. The arrow is pointing to the pars fracture, which you can see, and you can see the slight migration anteriorly of that vertebrae. And you can also see that it pretty much looks like a D1 disc. That disc is fairly parallel. The disc space is parallel. The end plates look very parallel there, along with the spondylo. So this all kind of makes sense. based on the mechanism of the injury and how new the injury was. You could also see the compression fracture at L1 at the top of the picture here. Then at L, so 5, 4, 3, 2, 1, and then L5 with its spondylo with a pars fracture. The disappointing thing with this patient is he did not come back for a second visit because he did not want any of his medical information getting back to his workers' comp company, because that's a no-no when you're self-employed and you own your own company. You do not want workers' comp claims against your company because that increases your rates of insurance. So he basically walked out of the office, says, I'm not coming back, and don't send anything to my insurance company, and walked out. And I don't know whatever happened to him. I do know recently that I know someone who was in contact with him said he seems normal. I don't know what that means, but I have no idea how his back is doing or if he's had any other treatment since then. But this case, I was able to predict the injuries based on the mechanism of injury and the signs and symptoms that were related to me through the examination and the patient's description of what happened. What is the line of correction for the listing BP? You should all know this one. It should just roll off your tongue. If you're thinking about this, give you a second to find the answer on the page here. The answer is C. Remember that a BP correction is a disc correction because you're adjusting the sacrum back to the lowest lumbar. That's P to A and S to I. The S to I is for the disc plane line. And that's the answer to that. Put this picture on here as a reminder that you have access to this textbook. Since it is no longer in print, and they're not going to print it any longer, you do have a full access to this book online. If you go to the website below, Dr. Plogger has made this book available chapter by PDF. So feel free to go there and download this book, and you can have all the information that's in there. This is the book that was written to back up to give all the information and scientific validation to the Gonstead textbooks. And here are your review questions to make sure that you know these important points for this lesson. And have a great day, and I'll see you guys on the next lecture.